Headaches are incredibly common, and if you want to take a really good history, you need to know nuance. And this comes with experience, but unfortunately, it takes a long time to rack up that experience. I don't want you to learn things off textbooks because the reality is that's not what you're going to see in clinical practice. So what I want to do today is just talk you through how I take a history to make a diagnosis of a migraine, or could this be something else that requires further investigation? I want to give you practical, real-world tips and clues. I want to give you hints, red flags that you really need to look out for, when to investigate, when not to investigate. My name is Dr. Prashanth Ramachandran. I'm a consultant neurologist. I'm also a laboratory head, but more importantly, I'm the founder of Basic Neurology. Over the last decade, I've taught over 4,000 doctors, and I've even converted quite a few into the beautiful dark arts of neurology. I want to demystify neurology so you love it as much as I love it. And I want you to understand the foundations, the basics, the nuance, and see how elegant and beautiful the specialty is. So if someone presents to you, be it in clinic, and says, I have a headache, based on the laws of probability, they probably have a migraine. And that's just because migraines are by far the most common headache type out there. And if it's bad enough for them to present to a doctor and complain about a headache, then it's going to be a migraine. So just based on laws of probability, migraine's number one on our list. Now, that doesn't mean the diagnosis is made, done and dusted in this YouTube video. It means that that's our starting point. When you take a history, you have a list of differential diagnoses that are in your head. And as you go through the history, you're constantly refining that differential diagnosis list. You're asking questions to say, is my leading differential diagnosis correct? I'm going to ask questions to validate that hypothesis. And if we're suddenly getting responses that don't fit that, that might move lower down in our list and others move higher up. So we're constantly refining that list based on the history that we're taking. So you need to understand how conditions present so that you can ask the important questions to try and make that diagnosis. So someone comes with a headache, the first leading differential is going to be migraine. We need to ask questions that are going to either help us confirm or refute our hypothesis. So we need to understand what migraines are to begin with. And the most important thing is that migraine does not equal really, really bad headache. That's the misconception. That's what people think in the community. This is what sometimes even doctors think as well. It does not mean really bad headache. So what is a migraine? Now, again, in the textbooks, we say it's a unilateral headache, and that's not correct. It can be unilateral. It has a propensity to be unilateral, but it can absolutely be a bilateral headache. And if it is bilateral, it tends to be more on one side. So if someone says, I've got headache all over my head, that doesn't necessarily rule out migraine. Not at all. The first thing I try to do is really tease out the characteristics of the headache. And these are very open-ended questions. I just say, tell me about the headache. Explain it to me. What does it feel like? They might start talking. They might start explaining. And at that stage, just let them ramble. Let them go for it. Let them tell you exactly how they feel. If they're having difficulty, that's when I give them options. And I say, well, does it feel like? And I give them the options that are there in the diagnostic criteria for migraines. But I also give them options that are not in the diagnostic criteria and are suggestive of other headache phenotypes or other headache disorders. So I might say, is it a throbbing, pounding, pulsing-like sensation? Does it feel like, and I always follow this up, does it feel like your heart is in your head, pounding or pumping away? Does it feel like a vice-like pressure? Now, those are the two qualities or characteristics that are in the diagnostic criteria. I also say, does it feel like a sharp stabbing pain, like a knife going through your head? Does it feel like a boring sensation? So I'm giving them different options if they're not able to give me a good description based on the open-ended questions. And so if they use the first two options that I've given them, vice-like, pounding sensation, fantastic, tick. We're already starting to move towards identifying what headache it is, more likely migraine. Again, pre-test probability, migraine's at the top of that list. Then I ask, where in your head is it? So usually they'll say unilateral, bilateral, worse on one side. Retroorbital pressure, so a pressure at the back of the eyes pushing forward, is a very suggestive history of a migraine. It's not like a cluster headache or a trigeminal autonomic cephalgia where it's a severe boring pain in the eye. It's just a pressure behind the eye. Now, what I said earlier in that migraines are not worst headache ever, the diagnostic criteria really says moderate to severe. So this could be a moderate headache. And this is a really important caveat. People can have migraines where it's building up. So if I was to catch a migraine super early, it might be 2 or 3 out of 10. It may not be that 5 or 6 out of 10 for moderate or 10 out of 10 in a full flung migraine attack. So you can have low level grumbling pain. If you leave it, if you do absolutely nothing, don't take any pain relief, don't take any fluids, nothing whatsoever, then it might build up. And so some people, and we talk about chronic daily migraines, can have a grumbling, mild headache. So moderate to severe is helpful. It makes us hit our diagnostic criteria, but not every single headache has to be moderate or severe. You can absolutely have a mild migraine. That's just grumbling in the background. And important to try and tease that out as well. So now that we've understood the characteristic, we need to think about the associated features, and these are important. There's 4 associated features, 2 of which group together to make 2 groups. So you have your migraine features. You either have to have photophobia and phonophobia, or nausea and or vomiting. The first group is photophobia, so light sensitivity, and phonophobia. So you have to have the combination of both. Now, photophobia is by far the most common feature that people describe. I'll ask them, do you have light sensitivity? And they'll say, yes, I have light sensitivity. I have to turn all the blinds off, close the curtains, go and lie down in the dark room. Now, not everyone will give such a clear history. Some people will say, I feel a little sensitive to light. Some people will say nothing at all. They'll say, no, I don't have any light sensitivity. But you have to tease this out. You have to push them. Think of yourself as, in Law and Order, and you're harassing the witness on the other side. You're trying to get them to spill the beans, and that's what you're trying to do. Don't coerce the witness, okay? Don't go all rogue on them. Don't coerce them or lead them. But what you're trying to do is really tease it out. So usually if a patient says, I don't have any photophobia, I push them and I say, do you ever feel like, you walk into a room, you just have to turn the lights off a little bit, or you're on your phone, it's a bit too bright, you have to take the brightness down on your screen. So you're really probing them, because a lot of the time patients don't think of this. They don't think, oh, I have light sensitivity. They just feel awful. Okay, they can't put their finger on it. And they say, actually, yes, now that you mention it, I'm lying there, I've got this bit of a headache, and I just want to, put my phone away. I don't even want to look at it. Very unlikely. Nobody wants to put their phone away. But sometimes you just want to put your phone away. Now, noise sensitivity, phonophobia, this is actually tricky. You have to have photophobia and phonophobia. But most patients will actually say, I don't have phonophobia, I don't have noise sensitivity. And this is when you really have to push them. Really, really hard, you have to push them. And you have to say, are you 100% sure? Do you have to turn the TV down a couple of clicks? Do you have to tell your kids to just shut up for a second and not talk so loudly? Do you have to go into a quiet room? And then they might say, actually, I'm a little sensitive to noise when I'm in the full flight of a headache. Now, what you might find is that as the headache escalates, these associated features of photophobia and phonophobia get worse. What you might also find is that your photophobia and your phonophobia are more predominant early on rather than the headache itself. And some people will say, before the headache, I get a little irritated with noise. I just tell people to, turn it down a little bit. So that's group 1. Group 2 is nausea and or vomiting. Not everyone has to vomit, but you at least have to have some level of nausea. You just don't feel right. You feel a little nauseated, and that's something you need to nail down. One of the last things we look at as well is exertion. So if you were to exert yourself, if you were to go for a walk up the stairs, it would make the headache worse, and you want to avoid exertion. This could even be Valsalva maneuvers. I say to patients, if you had this headache and I gave you the option of resting versus walking up a flight of stairs, would you avoid the flight of stairs? Would you avoid doing exertion? And most of the time patients will say, yeah, I don't really want to exert myself. So that is the history of a migraine. And you've got to tease these out. You've got to tease out each of these features to try and bring them out, because patients won't just say, yes, this is what I have. You have to tease it out. So if you start with knowing that my pretest probability is this patient has come to me complaining of a headache, it's going to be a migraine, and I go through and I ask all of these questions, if they come back and say, nope, 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 then I can push migraine all the way down to the bottom of my list, and I could look at other causes and other features. Now, as I take the history, if they were to say, well, I don't have a pounding, throbbing, vice-like sensation, I have a boring, like a knife stabbing me in my eye, and it just feels like it's this intense pain and my eyes watering, well, that's a completely different type of headache. Okay, that's going to be a trigeminal autonomic cephalgia, a cluster headache, something along those lines. And so as you're taking the history, you can rearrange your differentials and you can move down a proper path of what you think is going on. Let's talk about clues. So there's other clues that can help you figure out whether someone has a migraine. I usually take the history and then I look for the additional clues that can really boost my differential or boost my diagnosis. The first clue is that migraines are hereditary conditions. They run in families. You inherit migraines. So you'll get it from your parents, along with all their vices, as well as all their great qualities as well, depending on who you are, or depending on who your parents are. But the reality is, it's an inherited condition. It's a genetic condition. So I always ask, does anyone else in your family have headaches? Does anyone else in your family have migraines? And what you'll find is some people will say, actually, my uncle had it, or my aunt, or my kid, or my cousin. Delve into the history, try to find out. A lot of the time, that's going to be hard to say that's clearly migraine, but they might say they had bad headaches, or I always remember my dad having headaches. Second thing is catamenial headaches. So when patients have headaches during the time of their periods or ovulation, then it's much more likely to be a migraine. Migraines are hormonal. They move with hormonal fluxes. When someone says, I don't really get migraines, I do get the odd headache. When do you get the headache? And if they say around the time of my period, it's going to be a high likelihood that that's a migraine. Migraines tend to occur around the time of adolescence and puberty. And so again, if someone says I started developing headaches when I was 13, 14 years old, that's another clue. We can think of other triggers. If they say I'm dehydrated, or when I haven't eaten well, or I haven't slept well, then I get a headache. These are all typical triggers that we see with migraines. Now, another trick or a tip is that patients get a lot of neck pain. Now, neck pain isn't in the diagnostic criteria, but it's very common to get neck pain. Whenever I get my migraines, I always get neck pain. Actually, I get my neck pain first, and then I get my migraines. It's kind of like my warning sign. So always ask about neck pain. Neck stiffness, neck pain is just a bit tight. Some patients will say, whenever my neck flares up, I get a migraine. Well, is it the other way around? Do you actually get a migraine and you're starting to get neck pain at that stage? Another thing patients also sometimes talk about is they have increased urination and increased urinary frequency, and that happens a couple of days before they get their headaches. Very hard to tease out. Some people wonder you're a bit of a weirdo asking them that question, even though they're coming to see you about their headaches or their migraines. A couple more clues. Ice cream headaches. So you eat ice cream, you get a head freeze, a risk factor for migraines. It's part of the migraine phenotype. Final one is motion sickness, seasickness, part of that migraine phenotype that patients get as well. So I take the history, I look for these clues, and I also ask about the duration. Now, migraines are generally a couple of hours long. So we're talking a couple of hours, 24 hours long in length. If you take medications to try and blunt this, it can be shorter. If someone's complaining of a headache for 5-10 minutes, it's unlikely to be a migraine. Migraines are hour-long headaches. Frequency is helpful as well. If you look at the diagnostic criteria, you need to have at least 3 to 4 headaches of that characteristic before you can call it a migraine. So somebody presenting with their very first severe, horrendous photophobia, phonophobia headache, red flag. If it's their first presentation, you should be thinking of things like meningitis, etc., with the caveat of everything else that comes along with meningitis as well. But really, this is a headache that's recurrent. It's happening again and again and again. So when we think about headaches and somebody's coming with migraines, if it's slam dunk, fantastic. But if they're not fitting any of these criteria, that's when you have to start thinking, could they have another primary headache? And the main primary headaches that we think about are things like trigeminal autonomic cephalgias, which are things like cluster headache, etc. But you always need to think about secondary headaches. So these are bad headaches. These are not benign headaches that people live with through their lives. These are headaches that require urgent investigations or management, or to look in to make sure there's nothing else going on. If you're going through the history that we've just talked about and they're not fitting the pattern, you need to initially start shifting your differentials, but then you need to really be thinking about red flags. And I always ask the red flag questions, or I always have them in the back of my mind, regardless of what the history tells me so far. So what are the red flags? So SNOOP is an acronym that we can use. It's a good acronym, but at the same time, I can never remember acronyms. But I'll just talk about what I think about. So never forget that the patient is not in isolation. Don't think of neurology or headache as a single entity. Think of it in the larger context of the patient. The things you need to think about are how old they are. If a patient is over the age of 50, and specifically 55 and onwards, and they've got a new headache or a headache that has changed in characteristic, that's a red flag. And you need to investigate this with things like temporal arteritis. The other thing I think about is their immune status. So if they have cancer, if they're immunodeficient, if they're immunocompromised, if they're on an immunosuppressive agent, then that is a red flag. You need to think of the patient in the larger context. I work at a cancer hospital, and so whenever I get referred someone with a headache, I automatically say, well, sure, this is still potentially migraine, but I need to do the full gamut of investigations. I have to look into this in great detail to make sure I'm not missing something. And so specifically with immunocompromised patients or cancer patients, we want to make sure that they don't have an infection. We don't have some sort of atypical infection. We want to make sure that the cancer hasn't spread and caused metastases, etc. And you do see it. You absolutely see it. So you have to think about that. So we think about the age of the patient, we think about what conditions they have, and then we think about their systemic features. And so the systemic features are, do they have a fever? Do they have weight loss? Do they have night sweats? Do they have B symptoms? These are things that are important to take a history of. So we think of the age of the patient, we think of the actual immune status of the patient and their other medical histories. There's two things we need to think about with the headache characteristic itself. The first is the onset of the headache. So let's talk about the first one. So thunderclap headaches are headaches that come on to maximum intensity within a couple of seconds. At most 10 seconds, you need to get a CT brain, a CT angiogram, and you need to do a lumbar puncture, depending on what you find on the imaging, to look for blood or xanthochromia. The other things that we think about is position. So patients can have positional aspects to the headaches. If they're lying down and they don't have a headache, they sit up and they have a horrendous headache, and that makes you think about a low pressure headache, intracranial hypotension. They're fine when they sit up, they've got no pressure, and so the brain pulls down with gravity and sags and they get a headache. Vice versa, they might be fine and then they lie down, the pressure builds up in their skull and they get a headache. Now, the vast majority of patients with intracranial hypertension do not present like that. Okay, that's kind of medical textbooks. The reality is most patients will present with migraine-like features. It will sound like a chronic migraine. Not everyone will present with that typical positional component, specifically with intracranial hypertension. So like a space-occupying lesion, etc. So the way to help you differentiate that, apart from the history, is the examination. You have to look in the back of the eyes. You have to do a fundoscopy and you have to see if there's disc edema, i.e. papilledema. And if that's there, then we've got raised pressure. So just like you learn to listen to someone's heart, you need to learn to look at the back of the eyes. And for whatever reason, if you cannot look at the back of the eyes, get someone else to look at the back of the eyes. So every single patient I take a history for, headaches, I look at the back of the eyes. If you're in hospital, no one can look, ophthalmologists can't look, get OCTs. So these are optical coherence tomography. These are pictures at the back of the eyes. And for whatever reason, if you can't get them in the hospital, send them to the optometrist across the road, get pictures of the back of the eyes and send them back and look at them yourselves. Sixth nerve palsy, so double visions with sixth nerve palsy. These are classic signs of raised pressure. And any abnormalities in examination. If you've got a hemiparesis, focal neurology on examination, that's a red flag sign. So you have to do an examination. You need to think of the patient, you think of them at large. You need to look specifically for position in your history, and then you also want to do an exam. And if you've done all of that, and there's no red flag signs, you've ticked all the boxes, everything's fine, you can go on, you can make a diagnosis of migraine. Now, if it's such a slam dunk, clear-cut diagnosis of migraine, sometimes I don't get an MRI scan. Especially if it's a lifelong history, I've had headaches for 20 years, then I don't need to. Most of the times I will get an MRI. Most of the times I will get an MRI brain just to rule things out. But, in terms of the confidence I have, I would say that someone with a clear-cut history, all the risk factors, I will not get an MRI scan. And that's fine. If there's red flag signs, if there's anything that makes you stop and wonder that this isn't a primary headache, do your blood tests, do your MRI scan with contrast, and make sure, in some situations, get a lumbar puncture. Okay, so those are all my tips, clues, tricks to diagnose migraines from other headaches. There's a lot of other kind of nuances for the other different types of headaches. If you liked what you heard, please subscribe, because it means that I am doing something that is helping people. I want to help you guys understand neurology and the simplicity and the elegance that's there. The special bonus that I wanted to give you is everything we've talked about summarized into one page. If you're sitting in clinic, you can bring it up, you can make sure that you hit all the major points. I'm going to put that into a Notion template. You can get that completely for free. Sign up for our newsletter, get up-to-date information about what's happening from a content perspective as well as updates in the field.